everyone, and welcome to EuroPCR 2021. Unfortunately, we're remote, but we're very, very connected. And welcome to this session sponsored by Terumo on short duration of DAPT in high bleeding risk patients. Are we ready for prime time? I hope we are, I don't know, and I'm really looking forward to the Master DAPT study, which will be presented in this session. My name is Roxana Mehran from Icahn School of Medicine, and I'm really thrilled that I have an incredible panel here. Dr. Davide Capodanno from Catania, Italy, Professor Marco Valgimigli from Lugano in Switzerland, and Dr. Pieter Smits from the Netherlands in Holland, in Rotterdam. So let's begin with the learning objectives, and I'm really thrilled about this wonderful session. Are we really ready for prime time? I'm hoping that today we will discuss the framework for the decision making on DAPT duration in HBR patients and understand the implications of the available evidence and gaps in knowledge. We also want to really talk about Master DAPT and the implications of that very, very important trial led by Professor Valgimigli. I'm really thrilled to have our first speaker, Dr. Davide Capodanno, who's going to talk to us about DAPT in HBR patients. Where are we today? Professor Capodanno.
Thank you, Roxana. So my task is to discuss dual antiplatelet therapy in HBR patients. Where are we today? And these are my disclosures for this talk. I would like to start with the ARC-HBR criteria that were published in Circulation in the European Heart Journal in 2019. And you see here a list of major, minor criteria. Some of these variables are major or minor depending on the definition, but in the end, the status of HBR, high bleeding risk, is conferred to a patient if the patient has at least one major criterion or at least two minor criteria. So this is an approach that we call the semi-quantitative, which is a little bit different from the traditional bleeding risk scores that we use sometimes. Then another step in this kind of discussion was the trade-off between bleeding and thrombosis. This is important, of course. And the ARC-HBR consortium came with this trade-off model, which was derived using pooled patient-level data from 5 randomized clinical trials and 1 observational registry: Leaders 3, 1, and 2, Senior, Zeus, Century 2, and Paris. And then there was external validation in the Onyx 1 trial. You see that there are some candidate predictors of BARC types 3 to 5 bleeding, and there are some predictors of MI and or stent thrombosis. Some of these variables are actually predictor of both, and this is, of course, no surprise. But with the combination of these factors, you're able to identify 2 types of patients. You have a patient like patient 1 in this example, where the risk of MI and or stent thrombosis is higher than the risk of BARC 3 to 5 bleeding. And in a patient like that, you will try to intensify the antiplatelet therapy rather than reducing the length of dual antiplatelet therapy, for example. While in the second patient, you have a risk of BARC 3 to 5 bleeding, which is higher than the risk of MI and or stent thrombosis. In this patient, you will probably try to reduce dual antiplatelet therapy rather than increase the length of dual antiplatelet therapy. So it's important to realize that we have patients who have only one of the 2 risks prevailing over the other. And in these patients, we can take decisions that will tailor, of course, dual antiplatelet therapy on the individual risk of bleeding and ischemia. Another initiative from the ARC-HBR is this one, Standards of Trial Design. And when I say trial design, I mean trials of devices and trials of drugs. And in this document published in JACC in 2020, we came with recommendations for population selection, intervention, selection, control, outcome, and timing when designing this kind of trials with devices and drugs. There are many trials of devices in HBR patients so far. Some of them use a drug-eluting stent as a control. Some of them use a bare metal stent as a control. And some of them are actually non-randomized and use historical cohorts or an objective performance goal as a control. In terms of strategies of dual antiplatelet therapy in patients who are at high risk of bleeding, we have many indications and recommendations now in guidelines. Essentially, there are three strategies that could apply to these patients. The first one is obviously to drop early the P2A12 inhibitor. And you can do that at 1 month, at 3 months in CCS and in patients with acute coronary syndrome. The other strategy is to drop aspirin. There are now recommendations on this potential in patients with acute coronary syndromes, while there is no corresponding recommendation yet in patients with chronic coronary syndromes. And the third strategy is the de-escalation, meaning that you switch from ticagrelor or prasugrel in ACS to clopidogrel in order to keep some level of protection from ischemic events and reduce bleeding at the same time. So, of course, these are evolving paradigms, but it's important to recognize that we now have some recommendations as well for this kind of practice. So in conclusion, the ARC-HPR has set a list of standardized criteria for defining patients at HPR and for the design of trials of devices and drugs in HPR patients undergoing PCI. DAPT strategies for reducing bleeding in HPR patients include the early drop of the P2A12 inhibitor or aspirin and de-escalation. Finally, multiple trials in HPR patients with indication to short DAPT have so far compared coronary devices, as we have seen, while trials of DAPT strategies for HPR patients are pending. One is target safe, and the other one is master DAPT, which we will discuss later on during this session. Thank you very much for your attention, and back to you, Roxana.
Thank you so much, Davide. This was really fantastic, a great overview. I'm going to go straight into a case that Pieter Smits has given us, and if we can kind of have those slides up, and then we'll have a nice discussion amongst the three of us. Unfortunately, Pieter Smits couldn't join us in person, and if it's okay, I'm going to try my best to show his slides. If you can put up those slides, please. So this is a case of an HBR patient that we probably will see almost every day in high volume cath labs. I'm leaving Professor Smits' disclosures there just for your view. But it's a 74-year-old woman who has a history of hypertension and paroxysmal atrial fibrillation. She's on apixaban, 2.5 milligrams, losartan, and amlodipine for her hypertension, and was admitted earlier this March to a referring hospital with chest pain and a non-ST segment elevation MI with troponins elevation and also anemia. She was in sinus rhythm with T-wave inversions infralaterally, and the echo showed normal LV function with hypokinesis in the inferior and mid-septal walls. Here's the ECG. You can see sort of T-wave inversions across the infralateral and anterior infralateral leads, and you can see here that the first thing they did is transfuse this lady with 2 units of packed RBCs, diagnosed her with a bleeding colon carcinoma and no metastases, and calculated her CHA2DS2-VASc score at 3, her HAS-BLED score at 4, apixaban was dropped, she was switched to aspirin and ticagrelor, and she was sent to coronary angiography. She meets criteria for high bleeding risk, according to ARC, with 4 major criteria, but also meets the criteria on precise DAPT with a score of 35. So imagine combining those two and evaluating this patient, and then looking at the guidelines that we just already heard from Davide Capodanno that basically states that only ACS and unstable angina patients have an indication for preoperative and angiography, and this patient goes to angiogram, and you can see this pretty severe stenosis in the right coronary artery, distal right, distal branches there, and then let me show you the left anterior descending artery, also across 2 major bifurcations, calcific disease. Even in the mid-right coronary, you can see it. I would say the burden of atherosclerosis is pretty high, and the trade-off would be very, very difficult to evaluate. So really good. You can see the different views here. Long lesion in a major LAD. And of course, you also see lesions sort of everywhere, three vessel disease. So, what is there to do here? And I think the question is that the heart team evaluated this patient with all of those bleeding risks. And it's very interesting. Our surgeons are always saying surgery first, CABG is always superior in triple vessel disease. But these are the intangibles where the patient and the surgeons are all feeling like, well, no surgery, bring me to PCI. So these are the discussion points. What do you do in a patient like this? So important about the complete revascularization of this patient. Do you do it all in one setting? What type of stent do you use? How do you handle all of the details regarding the bleeding complications, the choice of the antiplatelet therapy, the duration, and the de-escalation possibilities of some of the de-escalation issues? I think this is really a very big bunch of questions for which there are no real great randomized studies that are going to give us the answers to this. And here this patient was brought to PCI. And just to show you what Pieter Smits and colleagues did so beautifully, they basically treated this left anterior descending artery. And you can see post-balloon. They still preserve those diagonals. They use balloon. We probably would use some plaque modification because we really want to get the best possible results. We would be using imaging in our laboratory, but you can see here beautifully 2 stents with really very, very nice results, preserving and not performing bifurcation, stenting, preserving those side branches in this patient with using some balloon optimization, not putting further stents there, and really kind of coming out with a pretty good result. And you can see even collaterals filling the right coronary. They then approach this pretty complex right coronary lesion, complex revascularization important in a patient like this. And as you can see, they really worked hard and did a beautiful job here in coming out with a pretty excellent result. And then, of course, here you are with a very big situation of how long do you place this patient with dual antiplatelet therapy when, if at all, restarting NOACs in a patient who had paroxysmal AF. When do you do the colon surgery? This patient needs colon surgery. And then what do you do with the assessment of coronary disease after? Incredible amount for us to discuss, isn't it? And I think I'd like to kind of open this up to a little bit of a discussion amongst all of us, given everything that we've already talked about, and then we'll say what Pieter did. So I welcome Professor Marco Valgimigli here to the panel, as well as Davide. And Professor Capodanno. Let's kind of have a discussion about this. First and foremost, what do you do with complete versus incomplete revascularization? Let me go back to those earlier questions before we got to the answers to make sure we have a nice discussion around this. Let's start with you, Marco. You see the anatomy. You see what the guidelines say. What do you do? Well, how do you handle a case like this? I'm sure you have this in Master DAPT, don't you? These kinds of cases would fit nicely.
Thank you, Roxana, for asking my opinion. Well, this is indeed a very complex case. I agree. I think given the clinical complexity, even before the angiographic complexity of this case, I would try to stick to fixing the culprit lesions. With that said, here it's not so straightforward to infer what caused this ACS. So probably I would do something similar to what Pieter did. I would probably try to fix both LAD and circumflex.
No, I think you're right. Complete revascularization has to be on our plane, and maybe we can get Dr. Capodanno also on the screen so we can have a nice triple discussion. Would be great. You would all agree, complete revascularization, right? Can we get Dr. Capodanno onto the screen, please?
Well, having said that, Roxana, here a complete revascularization is a dream, in fact, because distal LAD is completely diseased. So basically, you need to treat what you can treat at the end of the day.
Yeah, I think so, but at least opening all of the significant lesions, and that to me is as complete as it would get. I mean, I think, bypass with the poor distal targets is not the best option in this patient. Davide?
Well, let's say complete revascularization, now the evidence is in STEMI, essentially. So if we transfer this to no STEMI, it's not as immediate because we do not have trials, but it makes sense that if we start revascularization, we should go complete. And it doesn't make any difference for the surgery if the patient gets one stent or two stents, because you are in trouble anyhow. So it's better to fix all the lesions may be significant, that right looks ugly, it's subocclusive, and then of course we enter in the other discussion, which is how to manage antithrombotic therapy.
Yeah, I mean, this is a really difficult patient, and it's incredible that he's found this case, but not only is this woman at a very, very high bleeding risk, she's at a very high ischemic risk, and by the way, she has malignancy that with a colonic carcinoma, presenting with severe anemia, requiring transfusion. So it's a bleeding patient who then requires and has a non-STEMI, and then will probably need to have her operation soon thereafter. So let's go to the dual antiplatelet therapies. What would you think is sort of the choice of drug in a patient like this?
It's a good illustration of the problem here, because of course we discussed a lot H patients, but then you have HPR patients with this kind of a thrombotic situation where of course you need some comparison of a shorter versus a longer duration, and that's why master DAPT is interesting in that respect, because I cannot be sure here that a simple solution is the good one for a patient with such a high bar disease. So let's say I know that of course we have to think of a bridging protocol probably here, because the patient will undergo surgery, and at one point in time the surgeon will ask us to stop the medications. It's also interesting in this story the role of the apixaban, because the patient was in the sinus rhythm, but the chat VASC was 3. So there is an indication for oral anticoagulation anyhow, because this is a paroxysmal atrial fibrillation. And so this entered the discussion about triple therapy, which is addressed by the design of a master DAPT, by the way. But I think this patient will have need for oral anticoagulation alone. Of course, not during the perioperative period, but removing the anticoagulation may be a risk, patient has risk for stroke as well.
Yeah, I mean, an incredible case. Marco, what are your thoughts here?
Well, this is indeed a very complex case. So if surgery, if my understanding is correct, is urgent/emergent, so we cannot wait, and I guess this is the case of this lady here, I would probably stop both aspirin and the oral P2Y12 inhibitor. I would start Cangro until the moment of surgery. I would have surgery undertaken in this lady, and then I would restart perhaps a DAPT regimen with aspirin and oral P2Y12 inhibitor for a few weeks. That's what I would do. I think in this specific case, the stroke risk is relatively small, so probably I would withhold oral anticoagulation during the perioperative phase, and make sure that the patient can tolerate at least for some days DAPT. At that stage, I would probably restart apixaban. I would say, given this complex scenario with a 2.5 BID, not full regimen. And then at a certain point, I would probably stop aspirin and leave the patient on apixaban, lower dose, plus I would say here, I can name the drug clopidogrel monotherapy. I don't think I would pick either Ticagro or Prasuga in this specific case.
Now, in the Augustus trial, about 6 days or so, average 6 days or so, the best result was in patients who received no aspirin, and about 6 days or so, and went on to have apixaban with a oral P2Y12 inhibitor. But a more interesting question is what do you think that there's a specific stent design that's better, or are they all kind of created equally? And I mean, I know that Master DAPT is such a huge undertaking with a single stent platform to really understand exactly this kind of an issue. I don't think any other trial will answer the question of this patient. But do you think that this is stent agnostic, or do we have to at least give some credit to the stents that actually did work to answer these questions?
So I think each stent should be considered a unique entity, because now the DES are so complicated, so complex, and they put together to simplify at least 3 layers of complexity: the platform, the polymer, which can stay or can go, the type of polymer, the drug, the kinetics of the drug. So to say that all DES are alike, I don't buy in. I think for each stent, we should probably run stent-specific or DAPT-specific study under a specific stent. Unfortunately, answering your very important question, Roxana, is almost impossible, because we would need basically to put head-to-head DES in a very short DAPT regimen. This study design does not simply exist. But the good news is that MAST-DPT will answer the question whether you can go as short as 1 month after Ultimaster DES implantation. If and how much the results of the study will be applicable to other DES, that will be basically unknown.
No, I think it's important. I mean, obviously in Onyx 1, there was a randomization for 1 month with 2 different stent platforms that showed no difference. And I think that's the reason why I asked that question, because I think it's important for us to kind of help our colleagues choose the best possible regimen, both on the pharmacologic side as well as in the cath lab with stents. And in my mind, I think imaging is crucial in a patient like this. Imaging the stents, making sure we have the best possible apposition, especially when you're contemplating taking them off the meds and putting them through surgery. The platforms are excellent, but also I think imaging helps a lot. Do you agree, Davide?
Yeah, Roxana, your remark about the procedure is more important than ever in HPR patients. I agree, because essentially you don't know what will happen in terms of DAPT duration in these patients. We typically write in the notes, yes, the mandatory period is at least 1 month, but please reassess dynamically, because if the patient can resist with the DAPT, maybe it's better because it's multivessel disease, diabetes, etc. But the prerequisite is the procedure. So if the procedure is not okay, there is malapposition, there is under-expansion, of course, we are at stake of jeopardizing everything. So at least imaging in this patient should be very much considered.
No, it's great. Let's go see and let's see what he did. Let's go to the slides now, and I'll show you what he did. And then we'll come back again to another discussion, see if you guys agree. So what he did is that he ended up discharging this patient on aspirin and ticagrelor for 2 weeks. He wanted about a 1 month preferable. And then, of course, afterwards, he would only then do the surgery on a single antiplatelet therapy and aspirin. And I think at this point, I think surgeons feel like they would operate on aspirin. So he's giving a 2-week period, maybe even a month. And then afterwards, he wanted to do an FFR of the left main and take care of that CTO of the right coronary, and FFR guided, sort of really going after the complete revascularization, perhaps because if the patient went to CABG, there would be that. But then 10 days later, this patient was readmitted with fever, chest pain, no troponin rise, and the antibiotics were started, and surgery is delayed now and probably not being operated, which is sad to see. But I really want to thank Pieter Smits. If we could go back to our discussion again and get the slides off so we can get our panelists back up. I really feel that it's incredible that he presented this case, and what a beautiful case that he's showing us. I was more in your camp about doing the surgery pretty quickly, and also using a cangrelor bridging, and not perhaps in the hospital, maybe sending the patient home, giving them a week or so to recover from all of this, the transfusion, kind of getting her back into some kind of a shape for surgery, and then bringing her back. And unfortunately, and I'm not so sure that I would go after those CTOs unless there was really, really a compelling reason. I wouldn't be going after those CTOs, but it seems like the fate of this patient is not that great. Thank you. And now I'm thrilled to have Professor Marco Valgimigli from Switzerland to talk to us about the Master DAPT study. Professor Valgimigli, welcome.
Thank you very much, Roxana, and hello, everybody. It's my privilege, in fact, to discuss how to close the gaps thanks to the performance of the Master DPT studies. Please have a look at my conflict of interest. So I think Davide already set perfectly well the stage. We do have multiple single-arm studies showing the feasibility of reducing the DPT duration down to 3, or some of them even to 1 month after PCI in high bleeding risk patients. However, I think it's fair to say that in all studies performed so far, the high bleeding risk patients have also been selected for being at the same time at low ischemic risk. For example, STEMI patients have been excluded in many of these. Complex intervention was not part of the game, and the number of lesions or vessels which have been treated was actually by protocol limited. We do have RCTs comparing stent platforms, for example, BMS versus DES or different type of DES, among others, in HPR patients. In this specific group of studies, the inclusion criteria were broader, and in fact, the studies mandated a protocol fixed DAPT duration, such as, for example, 1 month. But these studies do not answer the critical question with respect to which is the optimal DAPT duration undergoing, which is the optimal DAPT duration in HPR patients undergoing PCI. So to close the gap, we designed years ago, and now we are very close to completion, the Master DAPT study, where we screened 5,204 patients. And finally, we randomized 4,579 to either a short DAPT regimen consisting of 1 month or a more prolonged DAPT regimen across 140 sites in 30 European countries. Patients to be screened had to be HBR, meaning at least the fulfillment of one predefined HBR criterion. No further PCI had to be planned as the third requisite. They had to be treated with the Ultimaster DES implantation, which is a thin strut cobalt chromium DES, which is eluting sirolimus at very low concentration through a biodegradable polymer, which actually completely disappears in 3 to 4 months and is actually based on an upluminal gradient coat technology. Now, patients after PCI entered a sort of a run-in phase, meaning a mandatory 30-day DAPT phase, after which they were reassessed, and if eligibility was confirmed, they were randomized into the real study, which meant in the abbreviated DAPT immediately stopping DAPT and continuation of a single antiplatelet regimen or prolonging DAPT for an additional 2 months after randomization. The study had 3 co-primary endpoints pre-specified in a hierarchical order, being the NACE, the net adverse clinical events on a non-inferiority basis. If that is going to be fulfilled, then we're going to test the MACE, so the composite of death, MI, and stroke on a non-inferiority basis. And if also MACE is met in terms of non-inferiority, then we are going to test the superiority of the abbreviated DAPT regimen over the prolonged one on the composite of major or non-major clinical relevant bleeding endpoint. There are multiple unique features of the Master DAPT study I would like to briefly discuss with you. This is the only truly all-comer HBR patient trial, meaning that we have no exclusion criteria based on the presenting syndrome or the complexity, location, number, or planned treatment approach of the target lesions. The experimental arm is indeed a contemporary arm, as it does not impose the type of antiplatelet therapy during or after the EPT phase, as well as, of course, both in the experimental and control arm, and therefore, by definition, reflects current practice. In the experimental arm, we are also investigating the safety and feasibility of stopping concomitant antiplatelet therapy 6 months after the last stent implantation in patients in whom there is a formal indication to oral anticoagulation. And in fact, randomization, which is pretty important and unique, takes place at the time in which the treatment diverges in the two study arms, avoiding noise, meaning the event would occur on the APT, which in the first month is identical to both treatment groups. And also the non-inferiority hypotheses are based on reasonably small margins, which is reflected by the large sample size. So when the study will be completed, meaning few weeks or months from now, we will be able to answer a very critical question. Namely, should 1 month EPT become the new standard of care in unselected HPR patients treated with ultimatum stent implantation?
Thank you, Marco. That was a beautiful presentation. Really, we finally understand the Master DAPT trial. Complex design, but really important with the strategies that you've put in combination with multitudes of different ways of treating the most difficult patients. So congratulations to you and your investigators. Let's talk a little bit about some strengths of this and how it might impact guidelines, treating patients, etc. And let's come to you, Davide. How do you think this trial will impact how we treat patients?
Yeah, let's say, Roxana, I think this is a very good example of great collaboration between industry and academia, because obviously in the design there is a lot of academic input that makes this trial well designed, I would say, and robust. So it's very important when we will see the conclusion. So some points have been mentioned by Marco, but I would like to reinforce the point of randomization is not a PCI, so you avoid that kind of dilution effect at the very beginning. The non-inferiority margin is reasonable. There is a hierarchical testing of the endpoint, which I really appreciate. So I think there are all the good green points in the trial in terms of methodology that we will make us relax when we will enjoy the results, hopefully soon. For the guidance, this is important indeed, because in this moment the recommendations for HPR are very empirical, and basically they go in the direction of shortening, etc. We don't know whether this is safe enough in terms of rebound in thrombotic events. Master DAPT will address this question, I believe.
No, I fully agree with you, and I want to really congratulate Marco's design, especially his very, very big issue of going after non-inferiority in a hierarchical testing on ischemic. At first, he uses the net benefit, but then he wants the ischemic event to fit first before going after the bleeding, which is a little bit of a thing that I did, is went the other way around. I looked for bleeding first and then ischemic events. So I congratulate you, Marco, for your brave look into this trial. So we'll see how the results look. But let me come back to you. I would like to have seen multitudes of stent platforms. Do you think having a singular stent platform is a limitation or an asset to this trial?
Well, first of all, thank you, David, and thank you, Roxana, for your kind words towards the study. And of course, I'm taking the congratulations also on behalf of Pieter Smits, who could not join here today. I think selecting a single stent platform is a unique asset. The event rate after DES implantation is getting lower, and lower. And if you allow a mix of type of stent entering to such a study, you will never be able to decide whether that event is driven by a lack of the APT, or perhaps because you are on the APT, or because of the specific stent type. Of course, the answer the study will provide will be stent specific, but at least you will have a very clear answer for this specific stent. So to me, that's actually an added value of the study design, not really a limitation.
Yeah, so ARC-HBR came after you designed this with the use of precise DAPT score in evaluating patients who would fit abbreviated DAPT. Davide, what do you think? You think is this going to be an issue? And I think the precise DAPT score should point out the high bleeding risk patients, but I wonder if you think otherwise.
No, of course, in the document, we didn't want to be binding with respect to the inclusion criteria, obviously, and having the precise DAPT score in it as an inclusion criteria makes absolutely sense. I'm sure that with this entry criterion, we will have a lot of patients who are elderly, with OSC, with all the things that are in the document. It would be nice, of course, to know which proportion of ARC-HBR criteria is in the study, just for the sake of comparability with other studies. But of course, no doubt that this would be sick and frail patients with HBR.
No, I think it's really important, and I promise you that these will be ARC-HBR patients as well if they fit the 25 and above. I'm certain of it. Marco, so when the results do come out, hopefully they'll be positive. And if they are positive, then are you saying now that we can't translate this to all stent platforms? Is this just for Ultramaster?
This is a great question. And I remind myself discussing this point in 2017, when we were writing the ESC DAPT guidelines. And I took a very clear point in that committee as a chairperson. Look, when we speak about drug A and B, we give recommendations which are specific for drug A and B. We don't speak about P2Y12 inhibitors. We name them, clopidogrel, ticagrelor. So when we speak about DS type A and B, I think we should do exactly the same. At that moment, ESC was a bit reluctant to embrace this new paradigm because they were terrified by doing this. They would be labeled as less company-oriented. And so we took a sort of a compromise. If you look at the guidelines in 2017, we have generic recommendation in the tables, but we have footnotes which are qualifying that recommendation. I think that should be the least that the new guidelines will be doing with respect to acknowledging the implication of the master DAPT studies, which of course have still to come. But extending the results to other DS type will be completely unfair, not only to us, but also to our patients.
Well, I see that you feel strongly about this. Davide, I wonder if you're as strong. I'm not so sure I'm that strong. I agree with you, Marco. I mean, you go through all of this trouble. Here's a sponsor who's ready, willing, and able to do this with their stent platform in a large scale, largest ever study. And then for it to then be translated to everybody else riding on that train, it wouldn't be fair. I fully agree. And I wonder what Davide thinks about this.
No, thank you for asking my opinion. Here, yes, I kind of disagree because when I think of master DAPT, my concentration is on the DAPT strategy comparison. So for me, the stent is something in the background, and I would say that this is a drug trial exactly when I say leaders-free is a stent trial, it's not a drug trial. So in this case, probably I'm very concentrated on the comparison of strategies, and in my mind, the results will apply regardless of, honestly speaking.
And so, the guidelines, I think that's important, right? I mean, this is going to be the very first largest ever study that is going to look at different strategies of abbreviated DAPT with a singular stent platform. If this is positive, and then use of a risk score that then really kind of stratifies patients, what do you think is going to be the, how do you write this in a guideline document? Marco, you're in a guideline committee. How do you write this into a guideline document?
Well, it depends on the results, which at this moment in time are not known. At least I cannot disclose them to better say. So if all three primary endpoints will be met, I guess that would justify either a class 2A or perhaps even a class 1 with a level of evidence B, basically coming from one single study, showing that a 1 month DAPT regimen should be preferred or is recommended over a more prolonged DAPT regimen. Now, this option is there in the guidelines, but that has a level of evidence C, so it's only based on the opinion of the writing members, and that says may be considered. That could actually become quite a much stronger statement based for the very first time on evidence.
Yeah, I mean, I have to tell you, I'd be very interested in your second hierarchy, which is your MACE endpoint. Not so much on the NACE endpoint. I'd be much more interested in that. And then it really is about the size of the benefit. The size is really important. I think for us, the risk benefit, and then of course the how important is the size of the benefit. And I think that's an important thing for guidelines, and I think all of us consider those. So should we have some predictions before we leave? Like that could be kind of cool. Well, you
I
can't
cannot
predict
participate,
one.
Roxana. I cannot participate.
Maybe Davide and I. So, I mean, I'm thinking definitely the NACE is going to be positive. I think the MACE part is going to be kind of very, very close. And because we've been seeing that when you avoid and you abbreviate DAPT in patients who are at high bleeding risk, you're gaining a little bit on the ischemic outcome. So I'm not so sure the size is big enough to give them the p-value. But I definitely think the bleeding is definitely reduced. NACE is going to meet it, but I'm not so sure about the MACE. I think it could just be like that 0.1 or 0.07 or 0.054 p-value. What do you think? Davide? So fun, right?
Well, first of all, yeah, it's fun. Of course, we can be totally wrong, and I hope to be wrong, actually, because I think that the stop will be at the second stage of the hierarchy. So non-inferiority for NACE will be met. And exactly as you said, Roxana, I think we will stop at the MACE, which will be similar. So there will be no third stage. Let's hope I'm wrong and everything will be positive.
Let's hope we're wrong. Well, this has been a fantastic session. What a great way to end this session. Thank you both for your wonderful input. I think what we've learned today is that high bleeding risk patients can no longer be ignored. They can no longer be taken away from clinical trials. We are embracing them and trying to find the best possible way forward. They're both at a high ischemic risk as well as a high bleeding risk. Often they're denied bypass surgery because of their high complex disease and demographics. We must pay attention to them, and we must embrace these large randomized clinical trials that are now underway. And I think the Master DAPT study is the largest of its kind that's actually looking not only to evaluate these very high bleeding risk patients, but also using a strategic way to randomize, using a risk score to randomize them to an abbreviated DAPT versus continuing the DAPT longer. And I think that, in my mind, is one of the biggest and important assets that we need for answers to the questions of the clinical questions we need to have done in our patients. Thank you for your attention. Thank you, Terumo, for sponsoring this important symposium. And thank you, EuroPCR, for including the high bleeding risk patients always in your programs.